So I think I know almost everybody here, probably everybody. I'm Justin. I'm one of the PGY4s. I just wanted to talk today about central venous catheters, take another look at them, some of the reported indications for them, and then whether we're using them correctly and some potential alternatives to those central lines. So going back to the beginning, we'll take a brief look at the history, when they started, where sort of some of the evidence for using them for specific procedures came from. We'll go and take a good look at complications associated with central lines, because that may be one of the big reasons to consider using alternatives. Look at the insertion method, or the preferred insertion method anyway, for central lines, and we'll focus there on IJ because that's where most of our lines go. Look at the alternatives, potentially for fluid management, administration of vasoactive medications, that sort of thing. And then briefly at the very end, touch on a few specific indications where central venous catheterization still does have a clearly defined role. So starting with history here, the first reported case was in 1733 when I think some English scientist put a glass tube in the left jugular vein of a horse and did some experiments on that. We didn't perform a central venous catheterization in a human until 1905 when a fellow called Blake Roeder did that in Germany. He didn't report it at the time because it wasn't believed to be of any value, and I think it was written up subsequently 5 or 10 years later. Also in 1905, Alberta was established as its own separate province, so we have that. And then the first reported use of a central line for medical management of a patient was in 1929 when a patient with purulent peritonitis was treated with medicine through a central line and showed some, they said, transient improvement, but unfortunately she deteriorated after that. Moving on a little bit now, in 1959, Hughes and his colleagues described a relationship between right atrial pressure and blood volume, or what they thought was such. They said, based on their experiments where they administer some radioactive isotopes and try and measure blood volume that way, in 25 thoracic surgeries, they said that they determined that right atrial pressure is an accurate and sensitive recording of the effective circulating blood volume. You can see the schematic there. They had a glass tube. It's not quite as advanced as we are now. And in their paper, they came to this conclusion but presented very little, if any, evidence showing reliably how they got here. And then now I'm sure a lot of you are familiar with the idea of putting central lines in liver resection patients to monitor CVP so that we can improve the surgeon's operating conditions and minimize blood loss. And this came about, I think, from 2 papers in 1998, one of which is this one, correlation between blood loss and IVC pressure during liver resection. So Johnson and that group, in patients undergoing either hemihectomy or extended hemihectomy, they didn't look at segmental or non-anatomical resections. But the surgeons put an umbilical artery catheter in the IVC just behind the liver. And they found here that you can't see the labels, unfortunately, it's quite small. But you see on the y-axis here is blood loss in milliliters. On this side is mean cable pressure. And there appears to be a nice linear relationship with higher venous pressures leading to higher blood loss. And their conclusion was that mortality and morbidity rates following liver resection are known to be influenced significantly by blood loss and blood transfusion. That's probably still true. But whether or not we need to monitor this in every case is up for some debate. The other paper from that year is this one here, central venous pressure and its effect on blood loss during liver resection, by Jones and colleagues. They looked at 100 consecutive hepatic resections over a 10-year period from 1986 all the way to 1996. So their data collection starting 30 years ago from today. And they also wanted to do something similar. They wanted to relate CVP to blood loss during liver resections. And then they carried on and did a multivariate analysis to try and mitigate any potential confounders. So they only measured it during the parenchymal transection. They put a catheter in the IJ. And the other thing with their study, their transfusions were all done to maintain a hemoglobin above 100. And so unless our patients have more severe cardiac disease today, I think our transfusion targets would be lower. So we should take a second look at this. They split into two groups. By the time they excluded the people they were going to exclude, they had a total of 92 patients, 40 where they kept the CVP less than 5 centimeters of water, and then 52 where they kept it above 5 centimeters of water. Of the 40 with low CVP, so CVPs below 5 centimeters of water, 2 of those patients required transfusion to keep their hemoglobins above 100, whereas in the group with CVP of 5 or above, 25 of 52 of them required transfusion. So a significant difference there. That significance remained whether or not the surgeons clamped the hepatic ligament. And then on this little chart here, the gray bars are the low CVP group, and the white bars are the higher CVP group. And you can see that significant difference in blood loss remained whether or not, like across all 5 different operations. So right hemiatectomy, left lobectomies, segmentectomies. There's still a significant difference. And so what they said is this altered their practice of liver resection. They now keep their CVP. In 1998, between 2 and 5 centimeters of water. They avoided fluid loading, gave nitro infusions if they needed it, reversed Trendelenburg, Lasix. And so like we mentioned, now with our transfusion targets are closer to 70, so I don't think this is valid anymore to base our interventions on. Moving on to our next objective, some complications of CVCs. So it's the important thing, it's not a benign procedure. It's, I think, sometimes treated as less risky than it is. And looking at NAP4, so the big UK study on airway events, over to like 2.8 million procedures in the OR, in ICU, in the emergency department. They had 184 airway complications, or severe airway complications, so that's 1 in about 15,000 or 0.006%. This paper here from the New England Journal, looking at intravascular complications of CVCs per site, where they took any patient who they thought a CVC was indicated. Do you want to have your words now, or do you want to?
I'm good. I have words.
Okay.
That's not true.
They did a 1-to-1-to-1 ratio, random allocation for any patient who they thought needed a CVC. For 3 sites, femoral, subclavian, IJ, and looked at the complications from that. And they had a primary outcome where they'd look at the incidence of major complications from insertion all the way to 48 hours after catheter removal. These complications in their primary outcome were either catheter-related bloodstream infections or symptomatic DVTs. And those are shown in the orange bar on this curve, symptomatic DVT from the central line, and then in the red bar, bloodstream infections. And also they looked at mechanical complications, so anything involving vascular access, pneumothorax, injury to carotid or jugular or other great vessels, hematomas, postoperative hemorrhage. And they didn't look at all of these, so they weren't looking for mechanical complications, as in, you poke the carotid with the needle, withdraw right away, put pressure, everything's fine. The only mechanical complications they looked at were what they termed grade 3, so complications requiring antibiotics, chest tubes for pneumothoraces, complications that were symptomatic and limited activities of daily living, required transfusion for bleeding, or if there was a hematoma, it had to be drained. And so you can see here, going from left to right, that's subclavian, jugular, and femoral. Looking at subclavian here, the percentage of complications, including primary and secondary outcomes, is 3%. For jugular, closer to 4%, and for femoral, about 3.5%. Of course, with subclavian, most of the complications are pneumothoraces, which you'd expect. But even looking at jugular vein complications here, it's almost 4%. And if you look at complications for something like radial arterial line, that rate is well under 1%. So when it comes time to think about using CVP versus things like stroke volume variation or PPV, I think that plays a role. Another complication, so retained guide wires after intraoperative placement of central venous catheters. This is just a quick single center study from Washington University in St. Louis. Over 6 years, they had 4 retained guide wires. And based on this small sample size, they calculated their incidence of somewhere between 1 in 8 and 10,000. couple things of note. All the lines were placed by residents, so we can take some blame for that. But in every case, the staff physician was also supervising and present in the room. And they found there's two main factors that contribute to guide wire retention when they reviewed their study, but when also they reviewed the literature, and that's the presence of more than one wire on the field. So if a wire is kinked or if it's contaminated and placed somewhere near the field, then you see it sitting there, forget there's another wire in, pull everything out, and there you are. Or inattention blindness. So the other issue was that all four cases had things that were distracting the primary operator from the procedure at hand, whether it was unstable hemodynamics or more learners in the room. And so their conclusion is basically don't have more than one wire on the field at a time. Make sure you're focused solely on the procedure. And then these, sometimes you can just remove them right away. You can take the central line out, the wire is still sitting there, pull it back a bit, reinsert. But often they're not found till later. There's case reports where they've been found, a day or two after surgery because of other findings on the chest x-ray that obscured this retained wire. And so then they require, whether it's removal by interventional radiology or operative removal, and then there's complications associated with that as well. You can also misplace those central venous catheters. So I think this is probably not super clear from anywhere but where I'm sitting. On the right side of that image, so on the patient's right, there's a central venous IJ catheter that's fine. But over here on the left side, if my mouse would like to make an appearance here somewhere, this is a dialysis catheter that's gone in the subclavian and artery, in fact, and is now sitting in the ascending aorta. And so they recognized this after they put the catheter in. They took out the dilator and they had pulsatile blood flow back. This is their CT scan here confirming that. You can see it sitting here in the descending aorta. And so luckily the patient did okay. It was removed and repaired by vascular surgery. But the big take-home message from this is, should you put a dilator or a catheter in, if there's any doubt as to where that is, if you're worried it's in an artery, if you're worried it's somewhere it shouldn't be, just leave it until until diagnostic imaging and the appropriate consulting services can confirm whether or not that's in the correct place. The puncture of an artery with a needle is somewhere between 1 and 11%, depending on various things, including patient anatomy, difficulty with the line, whether ultrasound is used or not. But the risk of actual arterial injury is under 1%. Other vascular complications, from central line placement include damage to the pericardium leading to cardiac tamponade, which there's well over 100 case reports of that. Mortality is well over 50% for that, bleeding into the pleural space, which is a problem because the wall of the vessel is so thin and it's such a low pressure space that you can lose massive amounts of blood in there before it's recognized. And on the left, or on your left on that image, you can see the SVC protruding into the pleural cavity and just how fragile that wall is. Pneumothoraces, of course, commonly with subclavians, and then damage to the mediastinum and hemomediastinum as well. If the catheter moves back, proximal ports can become extravasated and your infusions can go interstitial. And then there's also reports of nerve injury with an overall incidence of up to 1.6%. This includes damage to recurrent laryngeal nerves, sympathetic chain, brachial plexus, phrenic nerves, recovery in some of these cases taking up to 6 to 12 months. And so management, if you're concerned about vascular complications, make sure, can you aspirate blood through all lumens? So make sure all your ports are in a vein. You can transduce because they've shown that the absence of pulsatile flow does not absolutely rule out arterial placement. So transduce that pressure. And then make sure on a chest x-ray the path is consistent with a appropriately placed CVC. Again, if you're in doubt, leave it alone. Get diagnostic imaging and confirm exactly where it is. The other frequent complication of central venous placement, and it might occur more in ICU or more in emergency where it's put in less ideal settings, but that's catheter-related infection, and so that has an incidence of somewhere between 2 and 30 per 1,000 catheter days, or 80 to 189 per 100,000 patient years. The CDC estimates this cost, so in the US, at about $16,500 per catheter infection. So if trying to save the healthcare system money, it's important to avoid those. Mortality is up to 25% in some cases, and the more lumens there are, the higher the risk of infection. And that's, I think, just because if you've got more lumens, there's more access ports to contaminate. If catheters are left in more often for a long time, you can get catheter dysfunction where they fracture. Inside this box here, you can see that subclavian catheter has been partly removed, but there's still a nice chunk sitting in there. And you can also get fibrin sheath formation, which happens in even some cases less. That can occlude your distal ports, making aspiration, transduction, or infusion of medicines difficult to impossible. The other issue that can lead to complications with central venous lines is differences in anatomy. So you can have acquired or congenital differences. Acquired conditions are either things like thrombus or stenosis of the vein, and that's commonly caused by the central venous catheter itself. A third of all upper limb thromboses are related to venous catheters. Their risk is increased by the same things that increase your DVT risk, which most patients who have a central venous catheter have. So things like recent surgery, malignancy, chemotherapy, immobilization. And then up to 50% of dialysis patients who've had a long-term central venous catheter will have stenosis at that site. So if they come for an operation, you have to worry about stenosis in whatever site their dialysis catheter was placed in. External obstructions to the vein, so mass effect, 85% of those are malignant. So people with upper thoracic or neck tumors, some of the ENT patients or plastics patients, for example. And then you can also have congenital malformations that can increase your risk of complications, and that's things like left-sided or double SVCs, dextrocardia, or azygous vein abnormalities. And moving on, once again, throat's a little dry there. I'm talking about the insertion method for the central venous catheter. And we'll focus here on the IJ and whether or not we should be using ultrasound for that. So the image at the bottom here comes from a paper by Macon and Grau from 2007, but the quote at the top from a paper in 2009 actually says the internal jugular vein may be beside the carotid artery or in front of it, but it is never behind it, nor is it ever far away from it. And here they did an ultrasound anatomical study, and they've got the carotid artery in the middle, which says CA. And then on your left is the patient's medial side. On your right is the patient's lateral side. And up to 5% they found that this IJ sits somewhat medial to the carotid. And then if you look at that, in probably up to 50%, it can sit somewhere in front of the carotid. I think that's important, especially for vascularly depleted sick patients, where you may, using landmark techniques, end up piercing through front and back wall of that IJ without getting flashback, and then if it's in front of the carotid artery, you run the risk of puncturing the carotid as well. And I think that based on this quote where they say it's never medial, in those cases where it is medial, you wouldn't, I don't think, be puncturing there without ultrasound using a landmark technique. And likewise, if it's far away and lateral. And then other benefits of ultrasound are things like identifying thromboses, identifying valves that might be in the way, and obstruct your guide wire. And so there's several bodies have come out with some guidelines or some recommendations suggesting whether or not they think that ultrasound should be used to insert these IJs. The NICE group, so the National Institute for Health and Care Excellence, looked at 20 RCTs in 2002, 13 of these comparing ultrasound to landmark method for IJ placement. And they found that ultrasound reduces the risk of failed catheter placement, reduces placement complications, and results in taking less attempts to place a catheter. Their conclusions are that 2D ultrasound imaging is recommended as a preferred method for insertion of CVCs into the IJ in both children and adults in elective situations, and that 2D imaging should be considered in most clinical situations where CVC insertion is necessary, either electively or in emergency situations. The Royal College of Anaesthetists in 2012, and this is, I think, the third edition of this document, but they look at different ways to raise a standard, improving patient care. they looked at the NICE guidelines as well, but also did some more literature review and came to some of their some conclusions of their own. And they say 100% of patients undergoing elective central line insertion should have ultrasound-guided catheter insertion in the IJ. And that they think CVC should be inserted by healthcare practitioners trained in the use of 2D ultrasound. The Association of Anaesthetists of Great Britain and Ireland did a similar review. They found that ultrasound is definitely, or seems to be associated with improvement and reduction in complications in IJ placement, which they found didn't hold in placement in the femoral or the subclavian sites. But there is some literature now as well showing improved success of subclavian cannulation and reduced complications there using ultrasound. So their conclusions are that where ultrasound is available, it should be used routinely for CVC insertion. And that in the UK, as ultrasound is very widely available, they don't think it's any longer practical for staff to continue being trained to become fully competent in CVC landmark techniques. And I think part of their reason for that is the thought that, well, to be trained in landmark techniques, you have to perform those. And if there's guidelines and clear evidence showing that ultrasound's better, it's hard sometimes to justify practicing a landmark technique for a hypothetical situation that may occur in the future where you have no ultrasound and you need to place this under landmark technique. The ASA has a similar guideline. They recommend using real-time ultrasound guidance for vessel localization and venipuncture when the IJ is selected for cannulation. And likewise, there's a paper from the Anesthesia Society in Sweden from ACTA in 2014 that says there's, quote, compelling evidence that ultrasound guidance for CVC via the IJ is associated with a higher success rate and fewer mechanical complications. And this is all level 1A evidence, so systematic analyses of randomized control studies, and grade A, so there's consistent level 1 studies demonstrating that. So still, why would you place a CVC in the first place? So these are not all the indications, but some of them that we commonly use for CVP measurement for things like surgical management, and as it's been suggested, fluid management, and we'll touch on that shortly. Infusion of vasoactive medications, so we'll review a bit of literature on that. And then for rapid resuscitation, so sometimes things like MAC catheters help, where you can bang lots of fluid in a short amount of time. Hughes and their colleagues in 2015 looked at a systematic review and a meta-analysis of low CVP for liver resection. They looked at CVPs less than 5 centimeters of water, and they found that still it does reduce estimated blood loss. It does reduce transfusion requirements during hepatic resection. But what's shown here in this forest plot is that there's no difference based on CVP in postoperative morbidity or complications. And then not all the RCTs that have looked at this have actually shown reduction in intraoperative blood loss. So there's some conflicting evidence even in the single study set. I think our transfusion rates for liver resection here intraoperatively are 8%. You can compare those to places like Ontario, where it's up to 25%. And so there's obviously site differences as well. And I think part of the reason that you may have, yes, lower blood loss and lower transfusions with low CVP, but no difference in postoperative morbidity and complications is the idea that some of the interventions that we use to reduce the CVP may have their own set of complications. So things like diuretics, things like IVC clamping can potentially lead to hepatic, renal, and other organ dysfunction in and of themselves. And Rivers in 2001, he has that famous study where they talk about sepsis and goal-directed therapy and CVP resuscitation to 8 to 12 if they're spontaneously breathing, or 12 to 15 if they're ventilated. And the idea behind this is that if your right atrial pressures are low, so if you're on the left side of this curve, that a very small increase in right atrial pressure, so something like a fluid bolus, should have a significant effect on cardiac output. And where we run into issues is over on the right side, where you've already got fairly high right atrial pressures. And you see as the curve flattens out and you give more fluid, you significantly raise the right atrial pressure, but you have minimal improvement in cardiac output with that. And so we end up with these low CVP patients who end up, because they're already on the right side of that curve, they end up being over-resuscitated, over-fluid loaded. So this group, Merrick and his colleagues, have done this twice now. They did one in 2007 where they looked at whether CVP predicted fluid responsiveness, and they came to the similar conclusion here, where they say CVP is unable to predict fluid response among a broad range of patients in various clinical settings. And in 2012 they did this and they updated that. They came to the same conclusion. It's not, all the numbers in this aren't important, except on the right side there's the area under the receiver operating curve, which is basically tests, that area looks at how good your test is. And so when that area is 0.5 or less, the test is essentially worthless. An area under that receiver operating curve of 0.5 is essentially a random classification model. And on the right side here, where they look at CVP and the outcomes of cardiac output on fluid administration, all those hover around sort of 0.29, 0.57, 0.48. They're all right around 0.5 or less, which suggests it's not a great or not a appropriate measurement for volume status. And I don't have time to go through this whole diagram, but what this is, here's CVP right here, and here's 20 other things that contribute to CVP. And way up here in the corner is hypovolemia. So you've got CVP here, and you've got all these other factors, and one of them is hypovolemia. So I think this illustrates why, based on CVP, we can't reliably say that that patient is hypovolemic if their CVP is low. So it's fine to say, well, the CVP doesn't work for fluid management. It may not help with outcomes in surgery. But if we want to manage fluids, if we want to give vasoactive medications, we still need to give them. So are there other ways to do that? In looking at hemodynamic monitors, the perfect hemodynamic monitor would be non-invasive, precise, accurate, and provide continuous data. And so I'll focus here on stroke volume variation, but we also look at pulse pressure variation and ultrasound in the esophagus to look at flow through the IVC. So this group here, led by Ratty, did a randomized prospective comparative trial of stroke volume variation to CVP in laparoscopic liver surgeries. They had the same anesthetic teams for every patient, and they randomized them to two groups. One group with a stroke volume variation maintained above 12%, the other with a CVP maintained at less than 5 centimeters of water. And they used the flow track, so the same device we have here. And their conclusion is that if fluid restriction, if fluid restriction was insufficient to maintain these goals, they'd give diuretics. And then if MAP was less than 50, they'd give fluids to bring that up, but tachycardia wasn't an indication to give fluids. So the highlights are less intraoperative blood loss with the stroke volume variation group. There's no difference in morbidity, mortality, or length of stay. But I think that's open to the same argument that the interventions you give for low CVP, we saw previously that although there was changes in blood loss, there's no difference in morbidity, long-term complications, that sort of thing. I think this is still open to the same argument that the interventions that you're giving to keep that stroke volume variation high could have their own set of complications. And that's all this shows here. It shows there's a difference in blood loss, but in morbidity, mortality, functional recovery, length of stay, there's no difference between these two groups. Likewise, this group looked at stroke volume variation in hepatic resection, but open now, and they tried to figure out if it's a replacement for central venous pressure monitoring. So they looked at whether there's a correlation between your SVV number and your CVP number. They took two cohorts of 40 patients. First, they looked at CVP, then they looked at stroke volume variation the next 40. Surgical teams and anesthetic teams were not the same in this study. And they've seen here that there's a nice linear correlation between CVP and stroke volume variation. And so they say, in conclusion, the need for CVC and CVP monitoring is not necessary at this time for either open and or laparoscopic hepatic resections, and can be replaced with continuous SVV monitoring. And here, this is a PPV of 15, which they say correlates to a CVP of 3. And again here, remember the difference in complications. So IJ cannulation complication rate's almost 4% versus a radial artery cannulation is well under 1%. Looking not just at liver surgery, but also at major abdominal surgery, this group randomized patients to either stroke volume variation versus CVP-guided fluid replacement during their open abdominal surgeries, so during Whipple's, low anterior sections, retroperitoneal, tumor removals, and gastrectomies. And they maintained their CVP between 10 and 12, or their stroke volume variation less than 10%. So the opposite, we're no longer fluid restricting, we're giving fluid to try and maintain volume status. And they found that the mean volume of fluids given in the stroke volume variation group is significantly less than that given in the CVP group. And that's what's in that green box there. There's a shorter ICU stay for the stroke volume variation patients. There's no difference in requirement of vasopressors, return of bowel function, blood loss, or hospital stay. So they get out of ICU quicker, they get less fluids. Theoretically, there should be less swelling, and it should help with ERAS, although length of hospital stay here doesn't change. We can look now at stroke volume variation by itself, and whether or not trying to maintain that high or low affects blood loss during donor hepatectomies, because I still think we should be doing everything we can to minimize blood loss and optimize the operating conditions. So one arm here was maintained at a stroke volume variation of 10 to 20%. They gave 0.5 grams per kilo of mannitol and then fluid restricted. The other arm had an SVV maintained of less than 10%, and they gave these patients fluid at 6 to 10 mils per kilo per hour, so something similar to maintenance plus surgical losses. Differences in stroke volume variation were significant. Again, there's no difference in vasopressor use. They did also measure CVP, and they found that significantly lower in the high stroke volume variation group for what that's worth. And importantly, the surgeons were more happy in the high SVV group. And this curve, or the graph here on the y-axis, is blood loss. Group A is the high stroke volume variation group, so between 10 and 20%. Their mean was close to 10. It was 11.7% was the mean stroke volume variation for this group. And on the right side in the blue here is that low stroke volume variation group, so the patients who got maintenance fluids. And there's significantly less blood cell mass lost in Group A. The average was 145 mils versus 308 mils for Group B. So much less in the high SVV group. Again, no significant difference in creatinine, liver enzymes, serum albumin through post-op day 7. No difference in the incidence of AKI, no difference in hospital stay or abnormal radiographic findings. And so, based on the literature, CVP, if it's low, still leads to reduced blood loss from liver surgery, and you'd expect that because it still reflects the back pressure through that circuit. But it seems like stroke volume variation can do the same thing with a simpler intervention and less complication rates. And like I said, that's going to be the main focus. I briefly want to touch on intraoperative fluid management with PPV because it's available on all our monitors here and some monitors at other sites. This group looked at intracranial tumor excision, either lateral or supine, so not sitting up, and they randomized them to either a CVP of 5 to 10 centimeters of water or a radial pulse pressure variation of less than 13%. There's a trend, but not a significant one, towards higher blood loss and blood administration in the PPV group. And they found that the pulse pressure variation group gets more fluid intraoperatively, significantly, but that significantly higher numbers of patients in the CVP arm required fluid boluses postoperatively for hypotension and or tachycardia. And I think that higher need for fluid boluses for hypotension, is particularly important in neurosurgical patients where you run the risk of increased ICP and decreased perfusion pressure in the brain if there's episodes of systemic hypotension. And their conclusion here is that PPV can be used as a reliable index to guide fluid management in neurosurgical patients undergoing craniotomy if they're supine and lateral. Looking at transesophageal Doppler as well, this group placed the transesophageal Doppler probe in living donor renal transplant patients, and they did the intervention prospectively, but their control group was obtained retrospectively, so the study methods are not optimal, obviously. And their protocol was to give normal saline at 10 mils an hour until the anastomosis was complete, and then they'd look at this Doppler probe, and if the corrected flow time measured by that transesophageal Doppler was less than 350 milliseconds, they'd give hydroxyethyl starch, which I think is, interesting in renal transplant patients. But what they did find was that the transesophageal Doppler group got significantly less fluid administered than the CVP group, 12.2 mils per kilo per hour versus 22.7. And despite that big decrease in administered fluids, there's no difference in post-op urine output, there's no difference in graft dysfunction, there's no difference in the trend in creatinine. So of course, some of these alternatives have their own limitations. There's certainly conditions where pulse pressure and stroke volume variation are also less reliable. Spontaneously breathing patients, so septic patients in ICU, it's still not great. Cardiac arrhythmias, there's problems with it. For low tidal volumes or trouble with lung compliance, so restrictive lung defects, it's not the best way to measure fluid status. Many of the studies that look at SVV and pulse pressure variation have tidal volumes above 8 mils per kilo, so there's going to be complications there, or not complications, but certainly conflicts with sick patients in ICU. You ventilate them via the ARDS-NET rules, you should be at 6 or under, not 8. Patients with open chests, they're not that reliable. Increased intra-abdominal pressure, it says there's false positives here. We looked at the laparoscopic liver resection study, and I think the data there suggested that it works well. And then patients with right heart failure as well. This isn't a terribly accurate method of measurement. The other indication, or one of the other indications for central lines, is vasoactive infusions. So vasoactive drugs, norepinephrine, epinephrine, dopamine, dobutamine, vasopressin, as well as concentrated drugs, so things like calcium chloride or high concentration glucose solutions. I went through the product inserts for levofed, epinephrine, dobutamine, dopamine, calcium chloride at our standard 10 or 100 milligrams per ml concentration and D50. They all obviously say be careful of extravasation. You want to avoid it. Some of the higher concentration agents can be sclerosing, but none of them specified injection into a central vein. The closest I found was they talk about you should be trying to give them into a large peripheral, so something like an AC line. There's a study as well by Cardenas Garcia and her colleagues at a medical ICU in New York where they looked at 734 patients who received 783 different incidents of vasoactive medications via peripheral IV. These were things like norepinephrine. That was at our standard concentration, so it was either 32 or 64 mics per mil. There was some evidence saying that you shouldn't give it peripherally at, I think, a concentration of about 5 mics per mil. They also tried dopamine, and they used phenylephrine as well. We use phenylephrine here all the time, whether it's boluses or infusions through peripheral IVs. It wasn't short, so the average duration, or the mean duration of their infusions was 49 hours. In the 783 infusions, they had 19 cases of extravasation, so a 2% rate. This was treated in all cases with phentolamine and nitroglycerin paste, and once that treatment was applied, they had no further complications. The important thing here is that this was done in ICU. They developed a protocol that emphasized cooperation between nursing and medical staff, routine ultrasonography to make sure you were in a good peripheral IV, so not some tiny vein that you can get on somebody's thumb, and that there was good observation and really rapid identification of extravasation and prompt response to treatment. So in each case, they had the antidote in the room and available, so there's no hour delay between extravasation and treatment. It's treated right away. And then I didn't find any information on, or any studies infusing calcium at our concentrations or D50 through peripheral lines. I think the same thing applies. I think if you have to, you can infuse it slowly. Be careful, make sure it's a good IV, and just keep a very close eye on it. Cost is the other important thing to consider. So when we're putting in IVs, art lines, central lines frequently, each time costs a fairly significant amount of money. Looking at arterial lines, with the flow track, it's about $230, $220, that's the flow track. I tried to get the cost for a cut-down tray and a reusable gown, and there's some weird budget management where a lot of those costs come from the province. They're not hospital costs, and they couldn't have a cost for sterilization. So anyways, the disposables for an arterial line with a flow track come to about $220. And that includes gloves, sutures, angiocath, dressings. Likewise, for a CVP, with a 7 French triple lumen, which is $60 to $68 for that line, the cost is about $130, 68 of which is the line, 50 of which is the chest x-ray afterwards, including the $30 reading fee. And then there's also this RIC. So I haven't used one yet, but it's a rapid infusion catheter that's meant to go in a peripheral vein, and it's got a guide wire in it that can fit through anything above a 20 gauge, I think, 20 gauge or above. So if you have a 20 gauge in someone's AC and they come up to the OR with that from Emerge, if you take this kit, you can thread the wire. There's a little dilator, a little knife, and you can place this rapid infusion catheter, which I think is 7 French in the AC, and that works well. As well, it's a secure line, so if you want to give things like vasoactive medications peripherally, that may be a good choice, and it's, $18, plus the cost of the gloves and the prep. So of course, there's still specific indications for central lines, the things like transplant surgery, where it's still important to monitor CVP because you want to know the back pressure on those grafts, whether they're hepatic, renal, or other grafts. It still can be used as a marker of right ventricular function. So for heart transplants, right ventricular infarcts, pulmonary emboli, where you're concerned that that right ventricle is deteriorating and you'll see the right atrial pressures elevate. For long-term vasoactive or potentially sclerosing medications, chemotherapy, TPN, it's still likely more secure, and infusing it into a bigger vein is, I think, better for the patient than infusing it long-term into some small vein. For dialysis catheters, we need central access. And then for device insertion, so if you're going to transvenally pace somebody, you need to be able to access that. Thanks to Dr. Bishop for all his help, and for Jason, one of the anesthesia techs, and for Michelle Romanich, and she helped a lot with pricing as well.
I'm just going to interrupt because
all
they're going
I've
to
got.